Hello, and welcome to this special ACR review podcast brought to you by the Lupus Forum. My name is Ed Vital. I'm a professor of translational medicine at the University of Leeds and the chair of the steering committee for the Lupus Forum. And today I'm joined by Maria Dall'Era, who's a professor of medicine and chief of the Division of Rheumatology at the University of California in San Francisco, USA. Welcome, Maria.
Thanks, Ed. It's great to be here with you.
Did you enjoy Chicago?
I did. I thought it was an excellent meeting, a lot of great lupus content, and wonderful to catch up with friends and colleagues. What about you?
Yeah, it was that absolutely. I mean, I kept saying I'm so busy, I've got so many things to go to and so many meetings, but that's not something I should complain about, is it?
I feel the
So,
same way. And just to remind our listeners too that it's nice that all of the sessions, most of the sessions are recorded, right? So people can go back and look at some of the sessions that they missed.
yeah, it's a pretty amazing resource and it's available now. So in this podcast, we're going to discuss what we found most interesting at ACR. There's loads of lupus content, and there's too much for us to talk about it all today. So you can still look on the website. There's the highlights brochure that lists things that might be of interest, and then you can find it in the on-demand sessions. We identified over 40 across the conference that we picked out as highlights that cover lots of different topics and therapeutics. And also, just for listeners, if you want to be informed about similar key abstracts for rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, and scleroderma, then there are highlights brochures and preview podcasts for those disease areas on the IMID forum and the scleroderma forum. But let's get back to lupus and let's get into it. So, one thing we said when we did our preview was, as several recent congresses, there's been a lot about CAR T therapy and related sort of innovative therapies. So I took a look at a few of those. Shall I go through those first? So there was a nice plenary session called Rules of the Road, which the first talk in that was by Joan Merrill, and I think that's a really good one to watch because she gave a very nice, easy to understand summary on where we're up to in terms of clinical evidence for CAR T. So I thought I enjoyed Joan gave very sort of thoughtful and quite somewhat critical review of some of the evidence, I think, that I found quite thought-provoking. So firstly, she talked a bit about the complexity of the intervention, that it's not just the CAR T cells. Do the other treatments that we give play a role? The leukapheresis, the methylprednisolone, the fludarabine, and cyclophosphamide. And then she presented a sort of review of all the existing efficacy that's been written that summarizes things from 16 studies, 145 patients, treatments that target CD19 or BCMA, overall rates of DORIS, remission, drug-free remission, changes in the SLEDAI score, what's been said, the relatively low rate of cytokine release syndrome and ICANS that's been reported, ICANS being one case each of 1, 2, 3, and 4, and rates of serious infection. So that was a very helpful summary. She gave some cautions. For example, it's obviously exciting when we see a lot of high rates of remission and sometimes and often drug-free remission. But what Joan pointed out is if you look at, say, some of the older studies of, like, say, rituximab when it's combined with cyclophosphamide, the remission rates aren't as high as in the CAR T series, but they aren't that far off either. So she also pointed out that maybe are we sure that outcome measures like SLEDAI remission really ensure there's no active disease at all? And then she talked about this phenomenon that's been reported called LICATS, which is a kind of a local immune cell, so it's inflammation. So it's described as a kind of a complication of the CAR T therapy, where you might get inflammation in the skin or joints or kidney that's quite short lasting. And the authors of these studies have said the patients are in remission for their lupus, but they had LICATS. And Joan was careful reviewing is, are we sure that's a separate thing, or is it just some kind of lupus flares that were going on? So I thought that was very worthwhile. And then the other part of that talk was a talk by Maximilian Koenig, which I'm not going to go into as much detail because it's a little bit more complex, but he really covers some interesting things about some of the other innovations in therapy that are going on that are much more sophisticated. So here we're talking about CAR T therapies that target specific types of B cells, not just all of them, the ones that are causing the disease, like an antigen specific way or a class of B cells that are more relevant. So that was a really interesting session. There was another session called Driving the Car. And again, I'm not going to describe it all in detail, but it was like a conversation between Iñaki Sanz and Nan Shen about some of these more sophisticated approaches. And again, do we want to target CD19? Do we want to target BCMA? Is it about plasma cells? Is it about this 9G4 subset of B cells? Is it about specific B cells? Or even the thing that Max mentioned, which is even in vivo generating CAR T by giving mRNA. So both of those, I think, for anyone who wants to get up to speed on this topic, well worthwhile. And then there were a bunch of abstracts. Again, I'm going to cover them quite briefly because the messages are quite similar from a lot of these, but just to make listeners aware of what's out there. So the Castle study, abstract 0641, that's an update on the Salangan series that we've been hearing about a few times. So there's some more evidence in there. That was an oral presentation. They've got 24 patients, 10 with SLE, but they've got the longest follow-up. So that's really telling you about durable remissions. And then the others were shorter follow-up, but a range of different products is the interest. There's one from Peking University, 0647 by Zhao et al. 6 SLE patients in there. SLEDAI's better. Complete renal response. They've listed 2 out of 6 so far, which is okay, it's all right, but it's not everyone in remission yet. There's one from BMS, that was abstract 1527, again presented by Gail Chet. The innovation there is this rapidly manufactured CAR. So it does the same thing as the CD19 CAR T, but you make it much quicker, so it's a much better turnaround for a patient who might be sick, whereas that's important. There was one called CTA313, which is a combined CD19 and BCMA. So that's targeting plasma cells as well. 7 patients there, quite short-term data so far. And there was one about something called another study from China called A319, and that's a CD3, CD19 T cell engager, abstract 0646, that one. And they really call it preliminary evidence of immune reset. I personally thought it's a little bit premature to call it immune reset, but they show SLEDAI scores getting down and the safety pretty good. So yeah, lots to look at if you're interested. But I think the message to me is it's an emerging story. And I felt it's getting a bit more complex story in that not everyone's complete remission, and the number of different products out there is getting more complicated, isn't it?
Yeah, that was such a great review, Ed. Thank you. And just to add to that, on the very last day, the Wednesday of the ACR, in the oral abstract session, there was a very nice abstract presented by the group from Columbia, Anka Oskanese's group, who performed a systematic review of where we are with CAR T. So looking at various antigenic targets, CD19, BCMA, and kind of giving an overview of the data. So that might be of interest as well. And looking patient by patient at reduction in SLEDAI scores, DORIS remission, LLDAS, and then some of the serologic results as well. So that would be also interesting.
Probably more useful than all these 6 patients here, 5 patients there, 6 months.
Yeah, just to give an overview of where we are. But I agree
Yeah.
with you. I think it's such an interesting area and trying to understand where the technology is headed. And it's almost dizzying, right, to think about.
It is. It is. So maybe we should go a
know,
bit more down to earth on real things that are in the clinic then.
okay. So actually piggybacking on what you just spoke about in terms of B cell depletion, I thought I would start with a just high level overview of some of the data from some of the abstracts looking at obinutuzumab. And as our listeners know, there's a lot of interest now in obinutuzumab. In October, it was approved by the FDA for the treatment of lupus nephritis in combination with background therapy. And then two nights ago, we had a press release from Genentech showing the positive high-level results from the extrarenal trial, Allegory. A lot of interest here. And again, this theme of B-cell depletion, how best to achieve B-cell depletion in lupus. We have the cell therapies, but we also have the monoclonals, such as the glycoengineered obinutuzumab, which is a type 2 humanized anti-CD20. So just hitting some of the highlights, I liked the late breaker abstract looking at the subset of participants from the Regency trial who had repeat kidney biopsies. So just as a reminder, the Regency trial is the phase 3 lupus nephritis trial that had a positive result at week 76, favoring obinutuzumab over placebo in combination with mycophenolate in terms of complete response, and it led to the approval of this agent for lupus nephritis. There are 14 obinutuzumab patients and 15 placebo patients had repeat biopsies at week 76. And the goal of this study was to try to understand the depth of tissue B-cell depletion in OB versus placebo. And there was a statistically significant difference in terms of the depth of depletion. The obinutuzumab patients had excellent depletion in the tissue, whereas the depletion in the placebo patients was quite variable. So I thought this was very nice to be able to see what is happening actually in the kidney tissue, not just what is happening in the peripheral blood, because we really have to understand better what is happening in the tissue, I think, to try to pair that with efficacy for these agents. So that was a very nice, I think, proof of concept study in terms of what's happening in the tissue. And then paired with that abstract, there was another abstract looking at the pharmacodynamic effects of OB versus placebo in Regency, and specifically looking at decreases in total B cells as well as B cell subsets by high sensitivity flow, all in the peripheral blood. And what was shown, there's some nice graphs you can look at in the abstract, just showing nice decreases in total B cells, but also naive B cells, memory B cells, and plasmablasts through week 76. And looking at serologies, I find this very interesting when I look at the immune effector cell therapy trials, and again, small numbers, and then looking at other agents such as this anti-CD20, trying to understand what is happening to serologies in the peripheral blood. And what they found here in Regency was that there was normalization of anti-DNA in 42% of the obinutuzumab versus 16% of placebo at week 12, but those rates went up to 56% of OB versus 16% of placebo had normalization of anti-DNA at week 76. And similarly, greater improvements in complement in obinutuzumab versus placebo, not surprisingly. I still think it's very interesting that even at week 76, with multiple courses of obinutuzumab, it was still just 56% who had normalization of anti-DNA. I think it's telling us something interesting, right, in terms of which B cell subsets are making which autoantibody. And is that autoantibody actually pathogenic in that patient? Is it doing anything? If we're seeing complete responses and we're seeing complete histologic responses, what does that mean to still have that residual anti-DNA?
That's right, and that's something that was discussed in that session I mentioned. That Iñaki Sanz mentioned it a lot as well, which is like he doesn't really believe that the antibodies are truly pathogenic, and you've got to be cautious about when you get more specific to if you just did double-stranded DNA B cells or just did Smith B cells, it may not work. Yeah.
Very, very interesting. And then I'll mention another one here that also ties in, Ed, what you were speaking about. And this was an oral abstract also presented on the last day by Carlo Tour, who's from the Erlangen group. And this was a nice study of ultrasound-guided inguinal lymph node biopsies before and after several B-cell depletion agents. And what they looked at was rituximab, which of course is a type 1 chimeric anti-CD20, obinutuzumab, which we just spoke about, blinatumomab, which is a bispecific T-cell engager, CD19, CD3, and then they looked at CD19 CAR T. They performed immunohistochemistry to quantify various cell populations, as well as looking at follicular architecture in the lymph node. They looked at 24 patients, 7 SLE, 7 scleroderma, 1 myositis. And the bottom line from all of this is when you look in the peripheral blood, all of the patients had peripheral B cell depletion, except for one of the blinatumomab patients. And when you look in the tissue, what they found was all of the CAR T patients had complete B cell depletion with dissolution of the follicular lymph node architecture. In the OB patients, there were 4 of them. Only one of the 4 had full B cell depletion in the lymph node, but there was nice reduction in B cell numbers. It just didn't reach full depletion. Interestingly, obinutuzumab outperformed the T cell engager and rituximab, which I thought was interesting. And of course, that raises questions about why is that? Were there dosing issues? I think that we have to kind of work that out still. And I like the figures. I think, our listeners can take a look. I like the figures just showing the follicular architecture and trying to understand what's happening there. I think visuals are very helpful. So again, kind of trying to compare these different B cell depleting agents in terms of what's happening in the tissue itself. We saw the repeat kidney biopsies from Regency, and now we're looking at inguinal lymph nodes with these various agents. I found it very interesting.
It is really interesting, yeah. Yeah. And then of course in the sessions I went to, they were talking about there are, of course, extrafollicular B cells getting activated. So it doesn't might not we talk a lot about can we target the lymph nodes, but some B cell activity may not go through the lymph node. It may in lupus, it may go a different pathway.
That is an excellent point.
What else
Great.
was there?
Yeah, so maybe I can just quickly touch on some of the lupus nephritis urinary biomarkers, and then we can touch on some of the new and emerging therapies. Ed, does that sound good?
Yeah.
Okay. So I want to quickly mention a plenary that was given by Michelle Petrie, and this was addressing the question, it's a very clinically relevant question, at what threshold of proteinuria should we be biopsying our patients with SLE in whom we suspect the onset of lupus nephritis? And if you look at the 2024 American College of Rheumatology LN guideline, as well as the EULAR recent 2025 updated guideline, the threshold for proteinuria to trigger a biopsy is classically greater than or equal to 0.5. But the reason for that is because most of the evidence in the literature points towards that number. We had to come up with some threshold to give guidance to the community. But what we're realizing is that lower levels of proteinuria are associated with active kidney histology. And the field is moving now towards biopsying at lower levels of proteinuria. And I can tell you from my own personal experience, I biopsy at very low levels of proteinuria. And so what Michelle did in her group from the Accelerating Medicines Partnership was to look at this question. And they studied patients with SLE with no prior history of lupus nephritis who had proteinuria levels between 0.2 and 0.5. Plus, they had to have one other feature, either non-white race, a positive serology, or an active sediment. And these patients all got biopsied. They looked at 28 patients, very nice racial ethnic diversity. By the way, all of the patients had to be on a prednisone dose of less than or equal to 10 milligrams a day and no background immunosuppressives except for background hydroxychloroquine. They looked at 20 patients, and in the biopsies, they found, they looked at 28 patients. 20 of the patients had lupus nephritis. 2 had class 1, 5 had class 2, 6 class 3, and 7 class 5. And interestingly, already on that first biopsy with low level of proteinuria, a large number of patients already had chronicity on that biopsy. They found that the best predictor of having LN on that biopsy was low complement, more so than an elevated anti-DNA. And they found that when they looked at progression of proteinuria over time, 2 of the class 2s progressed, 2 of the class 3s, and 3 of the class 5s progressed to that threshold of 0.5 over time. In summary, I think this abstract is showing us data that we can see active histology and actionable lupus nephritis at lower levels of proteinuria. And data like this, I think, are pushing the field and pushing our clinical practice towards earlier kidney biopsy. And I think that we will see this in later iterations of guidelines.
Yeah. So all these new therapies, it's not just, as I'm often saying now about lupus nephritis, is like the best outcome isn't just about choosing a different medicine. Even though the new medicines are good, it's all about how you use them, how you make your diagnosis, how you administer them. The whole context of care is important.
Exactly. And catching the disease early, as you said, right? Screening early, diagnosing early, and then implementing the right medication at the
Yeah.
right time.
Yeah.
Absolutely. And along that theme of lupus nephritis, there were several nice abstracts, including 2 plenaries, looking at where the field has evolved in terms of urinary biomarkers. And much of these data were presented by Andrea Fava and his team from the Accelerating Medicines Partnership. And I thought I would just highlight a few things because I think it nicely provides some context for the abstract that I just presented from Michelle Petrie. We talk about early kidney biopsy. I've already mentioned this concept of repeat kidney biopsy, but where the field is moving is, can we use urinary biomarkers to help us understand kidney activity and predict response rather than always having to rely on the biopsy, because the biopsy can be very challenging to sometimes obtain, especially in many areas of the world.
Mm.
And so just to give our listeners some kind of highlights here, we know that Andrea Fava and his group from the Accelerating Medicines Partnership have shown us by looking at over 1,200 proteins in the urine from patients with lupus nephritis that there are different proteomic signatures with the various classes. And we see clear signatures separating class 3 and 4 from class 5, and particularly IL-16 and CD163 are most correlated with activity in the class 3 and class 4 on the first biopsy, signifying myeloid neutrophil signatures. We also know that these markers of activity change and they predict response, and that decline at 3 months predicts a good response at 12 months. We also know that if these proteins continue to be high in the urine at 12 months, they predict future EGFR loss. One of the plenaries looked at another marker of kidney function loss, and that is tenascin C. And this was a plenary looking at 170 patients from the Accelerating Medicines Partnership with a median of 5 years of follow-up. So looking at loss of EGFR over time, which is the outcome we all care about in our patients, preventing that from happening. They looked at 1,200 biomarkers in the urine, and at month 3, tenascin C was the strongest predictor of future EGFR loss. And what was really, I thought, interesting also about this abstract is they looked at single-cell RNA-seq and spatial transcriptomics in the kidney, and they isolated this tenascin C, which is an extracellular matrix protein. They isolated it to interstitial myofibroblast and also parietal epithelial cells. And remember, the parietal epithelial cells line the glomerular basement membrane. So I thought that was also interesting, showing what cells are producing this protein, which is highly associated with loss of kidney function over time. And the hypothesis here is that tenascin C is a marker of ongoing inflammation, remodeling, fibrosis, because tenascin C is also elevated early on in association with kidney activity. And what Andrea Fava described this as is, it's not a marker of, he used the term cold fibrosis or inactive fibrosis, but it's a marker of ongoing inflammatory activity, remodeling, fibrosis. So I thought that was very interesting.
Yeah.
And this outperformed proteinuria in terms of being a predictor of outcome.
So in future, instead of just monitoring protein, we might, as a whole, we might monitor individual proteins and say that one means inflammation, that one means the scarring, that one mean, and make treatment decisions like that.
I think that's exactly right. And then a paired abstract that was very, I thought, interesting as well to look at, looked at urinary biomarkers and histologic features in diagnostic biopsy and then a per protocol repeat biopsy. And this was 18 patients in this repeat kidney biopsy cohorts in Belgium and in Sweden. And along the lines of what you just said, Ed, it was very interesting where they found that um, on the baseline biopsy, which is diagnostic biopsy, IL-16 and CD163 correlated with histologic activity, but at the 1 year biopsy, tenascin C and BAFF correlated with histologic activity. So getting
Okay.
to what you just said, that there seem to be different biomarkers at different time points that are important.
And it's going to, with all these new therapies coming on board, it's going to be more important to customize them, I guess, to make the, we've got all these choices. Um, and maybe that's
Absolutely.
a good point. We could look, there's still things emerging about lots of the new therapies that are in phase 3
Yes.
trials as well. There's
Yes.
one I saw, there's a couple that I noticed. So there's one I presented, which was about ianalumab, which is in phase 3 now, but I presented a post hoc of the phase 2. And the purpose of that was to say, not just do you get response, but do you get time on a target? Like how many months do you get on LL-DAS? How many months do you get on remission? And there are some interesting aspects there, like that, that does differentiate the treatment groups to quite a large extent, and how the benefit builds up over time. The longer you have on the treatment, the more likely you are to get like these sustained remissions, which is important. And there was something quite similar I noticed on a study, I think this was Anchor again, about cenerimod, where reporting not on their phase 2 trial, it was a big phase 2 they did, that they analysed not just response, but sustained LLDAS, sustained remission, and again with a similar sort of message that it's quite differentiating. So I think that's an endpoint we'll see more of in trials as they come out.
Agree. And along those same lines, in terms of novel emerging therapies, I should mention enpatoran, which is a first-in-class oral, very interesting molecule, oral TLR7/8 inhibitor. And what this abstract looked at the Willow phase 2 trial program, which consisted of 2 cohorts. Cohort A was active cutaneous lupus or SLE with skin manifestations, but they had to have a CLASI score of more than 8. And then cohort B was primarily SLE with moderate to severe high disease activity with or without skin. And in this analysis, they pooled data from both of these cohorts looking at participants who had CLASI activity index of at least 8 at baseline, and they looked at outcomes in terms of cutaneous outcome measures, CLASI 50, CLASI 70, achievement of CLASI activity, scores of 0 to 3, which is kind of an emerging outcome measure of skin remission or good response. And they found excellent results with much better outcomes in each of these measures in the enpatoran group versus the control group or placebo on background therapy, and that there was early differentiation in these skin outcomes even at week 4. And I think this is recapitulating, some of the data that we've seen in other programs that have pointed to the importance of the TLR7/8 pathway, type 1 interferon, pro-inflammatory cytokines in skin manifestations of lupus.
Yeah. There were a couple on upadacitinib, which again, it's in phase 3 and they presented some phase 2. So again, they talked about time on target. There was one showing again differentiation of drug and placebo, and also about patient-reported outcome measures, generally showing, that people who get clinical responses in like SLEDAI BILAG based measures of clinical response had better patient-reported responses as well. That's another one to keep an eye on.
Absolutely. And then along those same lines, I could mention there were a few abstracts looking at post hoc analysis from the dapirolizumab trial, which
Mm.
is the molecule that targets CD40 ligand. It's this a pegylated molecule, no FC. And we all know about the positive results from the phase 3 trial in extrarenal lupus with BICLA as the primary endpoint. And there were 3 abstracts, again, along the lines of what you were just talking about, Ed, in terms of trying to understand the efficacy of this agent, dapirolizumab versus placebo, in terms of remission and LL-DAS. And they found that greater proportions of participants on the dapirolizumab versus placebo achieved LL-DAS and DORIS remission at week 48, and that there was differentiation at week 12 between the groups, which I thought was interesting. Another abstract looking at fatigue, musculoskeletal pain, morning stiffness, actually using the outcome measure that you developed, Ed, the
Oh yeah.
Lambda, which is quite interesting. And I love these abstracts and these analyses because they're getting at what is important to our patients living with lupus. So I find these analyses to be very helpful, and again, very positive results here, looking at fatigue outcomes as well as musculoskeletal outcomes with dapirolizumab versus placebo, which I thought was reassuring and intriguing. And then another abstract, again, post hoc analysis from the same trial, looking at the lupus qual and finding nice improvement across all domains of lupus qual, again, health-related quality of life with dapirolizumab versus placebo.
So that's something, an endpoint that's always hard to hit, isn't it, in trials? And then I guess just to finish up, there was some anifrolumab, of course, is an existing therapy that's in the clinic, but there's the trial in progress about whether you can use it in cutaneous lupus in people who don't necessarily have SLE. And although that trial's not completed, there was some real world evidence in support of that. So I thought that was it's kind of new actually in a way. And there were some comparisons. There's a few abstracts that were mentioned in the highlights, which I think people can probably find for themselves about belimumab and anifrolumab, real world data from some of the big registries, things like infection rate, earlier use, comparison to conventional therapies, things like that.
Absolutely. And maybe I'll just, if we have another minute, just to, again, with that foundation of anifrolumab, I just wanted to also mention there were 2 abstracts. One that I also really liked, it was an oral presentation looking at cardiovascular disease and lupus. And we all worry about cardiovascular disease. We know that all of our patients with lupus are at an increased risk for atherosclerotic cardiovascular disease. And we don't have wonderful ways to prognosticate risk. We're trying to learn and understand that. But there was a very nice study looking at autopsy data in lupus compared to controls. And I urge our listeners to look at that abstract. It was 1716, a nice figure showing all the various pathologic abnormalities in the heart in our patients with lupus, quite striking. But then there was a nice abstract that Zahi Tuma led looking at the effect of anifrolumab on cardiovascular damage, because I think this is the next frontier, is trying to understand how our targeted therapies, and we spoke about many of them today, how do they impact disease outcomes in lupus in terms of disease activity, but also damage, and specifically cardiovascular damage. This was a nice propensity score matched analysis looking at data from the anifrolumab long-term extension, the TULIP long-term extension, and comparing those participants to the Toronto Lupus Clinic cohort who just received standard of care therapies, no biologics. And this analysis showed that patients who received anifrolumab in the long-term extension, again, using propensity score matched analysis, had less cardiovascular damage progression than patients treated with standard of care in the Toronto Lupus Clinic cohort. So a nice, I think, exploratory proof of concept analysis, making us think about cardiovascular damage and how our therapies can impact that and improve long-term outcomes for our patients.
Absolutely. And it makes sense, doesn't it? Because of the roles of type 1 interferon in endothelial dysfunction and netosis and things like that. So, Oh, well, we could talk for longer, but I think
I
that's
know.
about all we have time for now. So thanks very much for that, Maria. And thanks to our listeners. I hope you enjoyed the review. Don't forget to visit Lupus Forum. That's lupus-forum.com, where you can find a lot of other lupus content. There's detailed slide decks of the top research that you can download for use in your teaching, monthly podcasts, and special webinars on topics of interest. And as always, best luck in your clinical practice.